ladies and gentlemen, we move on to the last lecture of this session. May I invite Professor Deedwania from Fresno in California, United States of America. Professor Deedwania for the next 12 minutes would be speaking on JNC 8 hypertension guidelines, comparisons and contrast with NICE ESC
due to cardiovascular diseases. For example, again here, the global prevalence of elevated blood pressure, you can see this is in men and this is in women. India is here, and you can see clearly the prevalence is estimated to be 25 to 30%. In the data that are shown here from 2014 paper by Lloyd Sherman, you can see when you look at comparison of the various countries, large countries of the world, Indian scenario is shown here. And clearly you can see that the control rates are just slightly better than China and Ghana, and clearly a lot more room for improvement. Even for prevalence and awareness, you clearly can see that awareness has improved over the last 10 years, but there's a lot more room to improve because it's less than 50% indeed. Well, when we look at the changes in prevalence of hypertension, with urbanization, with westernization of our diet and lifestyle, hypertension is rapidly increasing. For example, looking at these data here, comparing China, India, and other countries, you can see in India between 1988 to 2003, the prevalence of hypertension increased by sixfold. It was 6.6%, perhaps underdiagnosed during those days, and now recently thought to be about 36 to 38%. In the India Heart Watch study that I mentioned to you yesterday of 6,400 consecutive individuals at 11 centers, we can see that hypertension is not only a problem, as one would expect, in the elderly individuals, but notice here that people between 20 to 40 years of age already have a prevalence of hypertension somewhere between 20 to 30%. Certainly an alarming sign of the oncoming and further tsunami of the cardiovascular disease. What was even more alarming was the fact that when we look at pre-hypertension, for those of us who believe in pre-hypertension, those rates were extremely high in these adolescent or younger individuals, rates in the range of about 35 to 45%. Clearly, by age 50 or so, hypertension manifests itself, so pre-hypertension is less, but all these people eventually are going to develop hypertension, perhaps at a lot younger age than what we have known. And it has now been shown in a large study from China that urbanization is very responsible for increasing risk of hypertension. For example, here we can see the distance from the villages to the county, and clearly when you look at the mean blood pressure in this very large study in China, you can see the shorter the distance here, the greater the prevalence or greater the systolic blood pressure as compared to the farther from the urban area, the mean blood pressure was in the normal ranges. Now let me talk about the guidelines, because the new guidelines have been somewhat controversial, and I'll just highlight some of the points. This is the so-called JNC 8 or JNC late, if you will, because these guidelines have been under development for about 8 years. The JNC 7 that you're all familiar with was addressing prevention, detection, evaluation, and treatment. JNC 8 only addressed the issue of management of high blood pressure in adults because it was primarily based on evidence from randomized controlled clinical trials, took the risk factor, and the more darker the color, orange to yellow to orange to red, you can see that these people are at very high risk, and even orange, grade 2 and 3 hypertensive patients are thought to be at moderate to high risk. And the recommendation is that in these people, there should be prompt initiation of treatment in grade 2 and 3 hypertension with any level of cardiovascular risk, and they recommend this sort of very simple algorithm, if you will. They recommend single drug therapy for lower risk people, but for people with higher risk or higher blood pressure, at the get-go, they recommend 2 drug combination, possibly a fixed combination with better compliance, as we heard from Dr. Gupta. NICE guideline emphasize similar thing, except they emphasize that beta blockers should not be used, and they should be the 4th line agent, and these are mostly the older beta blockers. They are not talking about newer beta blocker, and this is largely because of the atenolol studies that have shown some adverse impact on stroke. And this is the WHO diagram that just says that lifestyle intervention should be an integral part also, not just the drug therapy, control of various factors such as weight control, diabetes, lipids, etc., is an integral part. But I want to present to you my idea that when we talk about countries like India, we should develop our own guidelines. Indeed, Indian hypertensive patients are quite different, so ministries of health or national societies should develop hypertension guidelines designed specifically, particularly for resource-poor setting, to replace complex and large impractical international guidelines for high-income countries such as United States or Europe. An approach that takes into global cardiovascular risk assessment from several risk factors into account is much more cost-effective, sensible, and that would be good to reduce the risk related to hypertension. Lastly, in conclusion, I want to suggest that when we talk about achieving hypertension control, we should go beyond cardiologists and beyond internal medicine. I think use of primary health care people, and I know Salim is doing a study in Kerala using nurses to go door to door to look at control of hypertension, should be the main source, because as physicians we have too many other things to take care of. Adopt a global cardiovascular risk approach as a strategy for drug treatment, eligibility for drug therapy, and one antihypertensive drug from each class, plus low-dose aspirin, etc., which is a polypill concept which you heard very nicely from Dr. Gupta, because most hypertensive people have multiple risk factors that are present at the same time. So this is a summary from the United Nations
Sorry for the interruption,
Conference on Hypertension. This is the last slide. Simple algorithm for screening treatment.
Enough time for one question per speaker. I request Professor Iyengar to please take over. Thank you.
No, I just want to inform him that we have formed guidelines by...
That this should attach, or maybe this is flash, and maybe they should distribute the pamphlet. And I think this would be a great help to the society.
I congratulate all the speakers for their excellent presentation. Friends, I am not a cardiologist. I am a community medicine professor at Government Medical College in Gujarat. And I have always been of a very strong view that clinical cardiology and preventive cardiology should go hand in hand if we want to really combat this scourge of non-communicable diseases. And I am extremely delighted to note that the eminent cardiologists, the AHA and API, they are now talking of the community-based interventions and also training of medics and paramedics and advocacy with MCI for incorporation of CPR in medical curriculum. So that's a matter of great delight to me as a community medicine person. We at our institution, that was my observation as a community medicine person, that the clinics that are being run in medical college for cardiac clinic and diabetes clinic, the clinicians were predominantly doing the job of prescribing the medicines, and they were not talking of the other interventions like dietary modifications or exercise or attitudinal changes or sleep management, etc., etc. So we took at our institute the initiative of establishing parallel lifestyle modification clinic, and we are supporting their work by advising the patients relating to all these aspects. And I suggest that from this forum, this recommendation may go that this untapped important resource may be utilized as a support for controlling and preventing this important...
Classmates, it's nice to see one as a speaker, another one as the chairperson. May I request Professor Deedwania to please accept the presentation.